Good afternoon, and thank you for joining us today. My name is Diane Hall, and I'm a senior scientist in the CDC Director's Policy and Strategy Office. I also serve as CDC's point of contact and coordinator for our rural health work. As part of our work on this response, we've been in regular communication with federal partners such as the Federal Office of Rural Health Policy, USDA's National Institute of Food and Agriculture, and the VA Office of Rural Health, as well as non-governmental partners such as the National Rural Health Association and the Rural Health Information Hub. We've had tremendous interest in this briefing, and we've received many questions ahead of time. Please note, if the question is not within CDC's purview, we have shared it with the relevant agency, and we will continue to do so. Also note that CMS launched a website on Medicaid.gov, which includes some new checklists to make it easier for states to receive federal waivers and implement flexibilities in their programs. If you search Medicaid COVID-19, you should be able to find it. And if you have additional questions, you may continue to send them to ruralhealth@cdc.gov. I'd like to thank Scott Miller and my CDC colleagues working on the coronavirus response for putting this briefing together. I would also like to thank CDC's Captain Margot Riggs and the Federal Office of Rural Health Policy for their assistance in curating questions and assisting with talking points. And thank you to our partners who helped disseminate the invitation. And I would like to welcome Health and Human Services Deputy Secretary Eric Hargan. Hopefully he's on the line. Okay, sounds like he's not on the line yet. So I'd like to turn it over to Dr. Jay Butler, who is the Deputy Director of Infectious Diseases here at CDC, and then maybe when the Deputy Secretary comes on, we can pause.
All right, thank you, Diane, and I will certainly yield to Deputy Secretary Hargan if needed. So good afternoon to those of you in the East. Good morning to fellow Westerners. And thank you for taking time to join this call today. We are in the midst of a global pandemic of a disease, COVID-19, caused by a newly recognized virus. And all evidence is this is a virus that has only recently achieved the ability to infect humans. Coronaviruses in general exist in nature, particularly in bats, and certain coronaviruses adapt to infect people. As some of you are aware, particularly if you're in poultry science or manage swine, influenza behaves somewhat like that. While the epidemic first evolved out of China, it has spread globally now, and some of the real global hotspots now are in Europe and in the Americas. All around the world, nearly 300,000 cases have been confirmed, and we're sure that many more cases than that are actually occurring. Unfortunately, nearly 13,000 people have lost their lives to COVID-19. It's important to recognize that the experience around the world suggests that people who are at risk of severe complications and death are those who are advanced in age, as well as those with chronic heart, lung, kidney disease, as well as those with diabetes. However, I want to stress that younger people also may have more severe disease. And while the overall mortality may be very low among younger people, the impact can still be significant. Here in the United States, there have been over 33,000 cases, and there have been cases reported from all 50 states. While a significant proportion right now are from New York City or from New York State, I want to stress that this is indeed a pandemic that has spread across the country and across Canada as well, so really all of North America. I understand that Deputy Secretary Hargan is on, so I'm going to pause. And Mr. Hargan, would you like to say a few words? Shall we continue?
Yeah. Yeah.
Well, I apologize for the dead air, and if the Deputy Secretary is able to join, we will let you know and interrupt again. Nationally, here in the United States, there have also been deaths as well as severe illnesses. Over 390 people have succumbed to COVID-19. A significant proportion of those have been residents of long-term care facilities, which I think again highlights the fact that those who are at greatest risk are those who are older and have underlying conditions. These long-term care facility outbreaks have now been reported from 27 different states. We do expect to see a continued increase in the number of cases, both as there's increased transmission and increased capacity to test. As of yesterday, 91 state and local public health labs, basically representing all 50 states plus District of Columbia and Guam, had capacity to do testing. There are also 5 commercial labs that are performing these tests as well. As we look at the mix of cases around the country, some are travel related, and when I say travel, I mean travel from other parts of the United States. Others are community associated, and so it's important to recognize that this is an infection that really is threatening the entire country. One of the challenges in controlling the disease is that it is apparent that some people also have very mild disease associated with infection, and it may be possible that people are shedding the virus prior to onset of symptoms, and some people may have no symptoms at all. Just today, CDC finalized and put out a report on some of the cruise ship clusters, and at least in one of the cruise ships, 18% of people who had documented infection never developed any kind of symptoms. Over the past week, there's been increasing focus on social distancing and the things that we can do to mitigate spread in our communities. And the reason for that is we want to be able to protect critical infrastructure, especially our healthcare system, recognizing that there is a small but significant portion of people who will become seriously ill, and we want to make sure that they're able to get the care that you need. You may see different actions taken in different states and different communities, and actually that makes sense because even though the virus is present around the country, in some states the transmission rates are higher than in others. Here at the CDC, we are working with all of our federal partners across the department and also with FEMA. And our particular role is to collect and analyze data to be able to provide technical advice to states, counties, and other partners to make good decisions. This is truly a learning curve, and it's very humbling to recognize how, despite the best science, sometimes what happens in nature can outsmart us. In some ways, a virus like this is like a tornado or a hailstorm. There's not much that we can do other than to be as prepared as possible and then be ready to mitigate the impact as much as we can. Of course, as I mentioned, we work closely with the state, local, and tribal leaders who are also organizing the local responses. We also work with the private sector, particular focus on ways that we can help support development of drugs that are effective for treatment, develop new ways to make the diagnosis, and ultimately to have a safe and protective vaccine. So all of this involves us working together. We recognize that there are particular challenges in rural areas. There's a lot of dependence right now on things like the internet for communications, whether it's with family or for teleworking. And in our rural areas, as well as especially in frontier areas, broadband and internet access can be quite limited. We also know that providers are oftentimes already overtaxed in our rural areas, and we want to do everything we can to help support them. Also, some of the things that are true when it's sunny and 70 degrees are true now in a pandemic, such as how difficult it can be to transport patients who are in need of a higher level of care. So with that, maybe I will pause. I can also pause one more time to see if Deputy Secretary Hargan has been able to join us in an unmuted fashion, and if he'd like to say a few words. Otherwise, I'll turn it back to you, Diane, and we can begin taking some questions.
Great. It sounds like we are having some technical issues. The Deputy Secretary is on the line, but is muted. So we'll wait to see if we can get that taken care of. So do we want to start with the chat box or take questions on the phone? How do you want to do this?
Sure, we can go ahead with the chat box. What is the current trajectory and outlook for patient surge around the country?
So it's quite variable depending on where you're at in the country. In some areas, hospitals are approaching maximal capacity already. As I mentioned earlier, New York City seems to be particularly impacted, and there's been a focus on being able to provide emergency additional rooms, particularly for people who are only mildly ill but still needing hospital care. It's also a chance to point out that most people who become ill can isolate at home and don't need to be in the hospital. So again, it's important to understand the vast majority of people who become sick will have relatively mild illness and can self-manage at home. However, because we're talking about a virus that may be able to infect everybody, even if the risk of the overall proportion who develop severe illness is relatively small, we may be talking about a significant number of people. So we want to make sure that we can provide care for those who are more severely ill. And it gets back to the discussion a little earlier about the role of social distancing and community mitigation. We're trying to flatten that curve, and I think now everybody has heard that term. It's a household word now. But to put it another way, if you're, say, running a hospital and you're going to you need to admit 100 patients, over a one-week period, that might overwhelm the system. But if it's 100 patients over a 2-month period, that may actually be something that can be handled very, very well.
Thank you. So another question came in that asks, do we know what the after effects are for those who are infected? Is this like the flu once it's over, or do we have lasting effects?
Well, that's a great question, and I say great question because that's one of the ones that we're exploring also. You know, the context of our discussion today, it's important to keep in mind that we're talking about a disease and a virus that was unknown to us only 3 months ago. We were all getting ready for the holidays, and COVID-19 was not in our vocabulary. Those of us in healthcare knew of coronaviruses, but only knew of 6, and now we've had a 7 quickly. So at this point in time, we don't have a lot of information. What information we have is mostly what's come out of China, which has seen the most cases occurring the longest time back. So far, it appears that many people do recover completely, although some may have persistent cough primarily. So again, it's not everyone who develops the infection coughs, but some who do and develop more severe respiratory tract symptoms sometimes have a persistent cough afterwards.
Will there be any guidance from the CDC provided to states regarding limitations to travel across states?
Yeah, that's also a very good question, because it sounds like that's somebody who's looked at the CDC travel alert page, which traditionally focuses on international travel. And currently the recommendations are very broad, with an increasing number of countries to which we recommend all non-essential travel be deferred. And really globally, we recommend anyone who is at higher risk of infection defer their travel until a later date. And the third thing I just wanted to make sure is very clear, we also recommend that no one should go on cruises right now, and the industry actually is in the process of suspending cruises, although there are still a couple of dozen ships that are at sea with people on board, including Americans. In terms of domestic travel, our recommendation right now is primarily where we talk about how to stay well if you're at higher risk. And those are the people, these are people who are older or have underlying conditions. We recommend that as much as possible you stay home, limit your interaction with other people, and that would also certainly apply to getting on an airplane, which can oftentimes be a crowded situation, and flying to another part of the country. It's also very important to know what are the recommendations and sometimes even regulations that have been passed on an emergency basis at your point of destination. A number of jurisdictions are now requiring people who come in from other parts of the country to self-quarantine at home for a period of 14 days and not return just straight back to work.
Will you please discuss current and future testing capacity?
Yes, so testing capacity is an area where there has been progress. I mentioned earlier the number of state public health labs that are now up and running with the CDC test. And many of those actually have been able to clear backlogs and are turning around test results fairly rapidly. We really appreciate the volume of tests that the commercial labs are able to do. That's a big heavy lift that is helping in this response. They're using some other methodologies, but these, as far as we know, these are going to be good results. There is a bit of a backlog in some of the commercial labs, so we are hearing of instances where the test results from commercial labs are taking a few days to return. We've also been told that that backlog should be cleared fairly soon. The other areas regarding diagnostic testing where CDC has been involved is making the virus isolate available to people in the commercial sector to be able to develop new tests. And I think the ultimate goal is to move past the PCR-based technology, which is fairly high-tech and is harder to perform in smaller and more remote locations. And I think the ultimate goal would be a test that might function more like a rapid flu test that could be in your healthcare provider's office. We're not there yet, but I know there are many people who recognize that that is a very high priority. One of the challenges, though, and I think this is impacting all of us, is that after some of the initial challenges we had with reagents at CDC, we then moved into the next stage of complications where many of the reagents as well as just the supplies to run the test began to become in short supply as the global supply chain has been limited. So I know that's frustrating for all of us, and there's a lot of smart people thinking about how do we best address these problems so that the diagnosis can be confirmed. And I think that's not had widespread transmission of the virus yet. In some places, you've probably seen in the paper, particularly in urban areas where there's been a number of cases, oftentimes providers and public health are moving more to a syndromic surveillance where cases are identified based on the symptoms. Although well, the caveat in that is I'll say we are still learning what some of the symptoms of this infection are.
Could you explain more thoroughly the term shedding the virus? Do the particles remain airborne for long?
Yeah, another great question. So shedding basically means that the virus is in secretions and are potentially infectious. The way we can assess that are a couple of different ways. One is using the diagnostic PCR, but the caution I would offer there is the PCR, polymerase chain reaction, detects the viral RNA. It does not tell us whether or not the virus is actually capable of infecting another person. What's probably more predictive of the risk of transmission is actually recovery of the virus through viral cultures. That's more labor intensive and actually takes a lot longer to get the results back. But it suggests that the peak level, based on the data we have so far, the peak infectiousness is probably very early in the course of illness. Concerns that there may be a period of infectiousness prior to the onset of symptoms, which makes the control of the infection through diagnosis and quick isolation or quarantine much more challenging. And this may account in part for how we've seen a fairly rapid spread of this virus around the globe. In terms of survival in the environment, there's two lines of evidence. One is what can we do in the laboratory under ideal conditions, and then what are we seeing in real world conditions. In the laboratory, we can make the virus survive on surfaces if the temperature is just right and the humidity is just right and the surface is just right. We can also aerosolize it into the air for a period of time. But the epidemiology points to the primary mode of transmission is probably respiratory droplets, meaning that when I cough or sneeze, I generate a spray which may have the virus in it and be able to pass it on to someone who's near me, generally within a range of about 6 feet. It also suggests that I could contaminate surfaces. And it seems reasonable based on what we've observed so far, as well as the experience with other coronaviruses, to say that these contaminated surfaces may play a role as well. So that's why when we talk about control measures, there's such a focus on if you're sick, stay home, wash your hands 20 seconds with soap and water, or use an alcohol-based hand cleaner with at least 60% alcohol. Cover coughs and sneezes, and wipe down surfaces with commonly available household disinfectants. One question that we get quite a bit is, what about things like mail or products that are sent around the world? Even though in the laboratory, virus can be detected on things like paper and cardboard, we're not seeing in the real world. Otherwise, I think we would have seen a lot more instances of the infection popping up in remote areas far away from China back in January. Whereas when seeing cases that occurred in travelers coming out of China or in their household contacts, people who had fairly intensive exposure with people who returned home and subsequently became sick. And that's why early in the response, we had so much focus on travelers and restricting travel to be able to slow the entry of the virus into the U.S. and around the world.
What can we do to support and help our farmers who are actively engaged in spring planting?
Yes, in terms of the actual act of spring planting, I think that's actually a very good example of a work activity. As I think back a number of years ago now, when I was working on a farm when I was an undergraduate student, and Monday, Wednesday, Friday, and Saturday, I mostly spent my time on a tractor or hauling hay. That is the kind of activity that should be able to continue, because it's not so hard to social distance as it might be in an office. Clearly, it's also an activity where teleworking is not going to put the seed in the ground. The measures that can be taken is to avoid a lot of interpersonal contact when you come back in off the field, and also do everything you can to make hand hygiene possible, ideally with water and soap, but if that's not available, an alcohol-based hand cleaner.
So we're hearing a lot in the news about shortages of supplies, and rural providers and hospitals, clinics, FQHCs often have even more of a shortage in terms of workforce, but also actual supplies that are needed. Could you speak to more rural specific suggestions?
Yes, and I think toilet paper is in short supply everywhere, urban or rural. But the issue of shortages of critical supplies such as medications, as personal protective equipment for healthcare settings, and particularly for our FHQCs, the FQHCs, the federally qualified health centers, is an area of concern. So this is where the national response, I think, is going to be very helpful in terms of the work that's going on at FEMA in partnership with HHS, Department of Health and Human Services, to be able to look at alternative supply chains to get some of that personal protective equipment out, and also working with HRSA to be able to do everything we can to support the FQHCs to not only have supplies, but also be able to manage the potential increase in patients, as well as apply good infection control practices, particularly when PPE may come into short supply. CDC's particular role in terms of PPE is addressing the demand side of the equation. What are the things that we can do to help preserve PPE? We've got a couple of tools online that I think can be useful to clinics and hospitals, whether they're rural or urban, to be able to assess the PPE burn rate and be able to project what their needs are going to be down the road. The response through the Assistant Secretary for Preparedness and Response is focused more on the supply side and ways to supplement what's available, including being able to provide what provisions are available through the Strategic National Stockpile.
Great, thank you. What should rural hospitals and clinics be doing to prepare for a surge?
Yeah, so preparedness is a very important part of all this now that we're actually in response mode. Almost all hospitals have done some type of pandemic influenza planning exercise, and they actually have a plan that is written out. Of course, they say plans are no good if they just sit on the shelf. So I hope everybody who is running these hospitals has had a chance to pull down their plans and think about what they learned during pre-pandemic tabletop exercises, and then how they'll deal with some of the unique aspects of this particular pandemic. Some of those unique aspects include healthcare workers who are unable to come to work because of school closures and lack of child care for their families. And then, of course, the concern that healthcare workers themselves can become ill. And not only do we want to make sure that healthcare workers are healthy and able to keep working, but also that they don't then become a mode of transmission to higher risk patients.
Great, thank you. How can we tell the difference between flu, COVID-19, and allergies, because it is allergy season in a lot of areas?
Yeah. There's a lot of overlap. So let me start with that. And of course, with COVID-19, it's a brand new disease, so we're still learning a lot about it. Flu and COVID-19 probably have the most overlap because fever, cough, muscle ache, headache can be prominent parts of both. Allergies generally don't cause fever, but I have also talked to a number of patients who had very little fever with COVID-19, or it wasn't the first symptom. So it's, I think, virtually impossible to anybody who walks in the door complaining of a runny nose to say for sure that which is allergy, which is influenza, which is COVID-19, but we continue to learn more about it. I know there's some reports now about things like altered sense of smell or a funny taste in the mouth being more common with COVID-19. I think at this point in time, those are really anecdotal reports, and they're intriguing and certainly merit more study, but we have no idea how predictive those type of symptoms might be for COVID-19.
Great, thank you. Since we're more rural and spread out, are we at less risk?
That's a very good question, and it depends on more your local environment than your, say, your county environment. So if you're in a a county with only 2 people per every square mile, that's a good start. But if you're in a household that has, say, 20 people in it, your risk may be similar to what it might be in a more urban area. I think in general, we will see slower entry into particularly the frontier areas because of lower volumes of traffic. But it's important to look at history and what we've learned from that. When we consider the flu pandemic of 1918, before we even had air travel, that was an infection that spread far and wide. And by November of 1918, after the virus first was fairly prominent on the east coast of the United States in September, it had spread even as far as the Seward Peninsula in far western Alaska. So I think it's reasonable to assume that while the entry into rural areas may be lower and it may be easier to do some social distancing because of the lower population, we shouldn't assume that any part of the country is going to be spared.
Great, thank you. Do we think this will go away during the summer, during warmer temperatures?
Well, the question about seasonality is one that I think we would like to think that it's going to go away, but it's important that we can hope for the best, but we have to be prepared for the worst. It gets back to our opening discussion about this is a brand new disease and virus. And while most respiratory viruses are less common in the summer, we don't know just how this one will behave.
Great, thank you. So for rural providers, should they be keeping well child appointments, physicals, those kinds of things?
So the decision of keeping I'll call them elective visits, really depends on the local situation. And it's concerning because we know that there are women who are pregnant now, they are still going to deliver. We know there are people with high blood pressure who still need to have their blood pressure checked. We know there are people with diabetes who still need to have their diabetes managed. And we know also that we want to keep our kids healthy. So being able to have those well child checks and get on-time immunizations is critically important. So it really is a decision that ultimately will be decided locally. Just very broadly, our recommendation from the CDC is to consider deferring non-emergent procedures or elective surgeries or visits to the provider. But just when to do that depends on the local situation. Because we don't want to do things so early that then things that aren't emergent become emergent by the time we're seeing a lot of spread of the virus locally.
Thank you. How should providers, hospitals, and clinics respond if patients call suspecting exposure or reporting symptoms?
Well, first of all, that's what you want to have happen, is have people call ahead rather than show up and maybe sit in the waiting room for a little while and then come back and say they've been coughing and have fever, and particularly if they've been around someone known to have COVID-19. So that call ahead is important. For clinics and hospitals, need to have a plan for how will you assess those people, and also make a determination of whether or not they need to come in at all. There is a tool available that CDC has provided online that allows someone to check their symptoms and determine whether or not it's important that they get in to see a provider right away. But of course, someone who's severely ill, short of breath, chest pain, blueness of the lips, these are symptoms of potentially a very serious condition, which might be COVID-19. That's the situation where a phone call is nice, but the phone call that needs to be made is really to 911.
Thank you. There's some questions about language clarification around isolation versus quarantine. What does it mean to self-isolate versus self-quarantine? And what should people be doing and not doing when they either self-isolate or self-quarantine?
Okay. Well, let's start with the definitions. And I know this is confusing because many people use these terms interchangeably, and they actually have technical meanings. And there's a reason why they're different words. Quarantine means you're removing people who've been exposed to an infection from those who have not been exposed. So both groups are not ill. Isolation is when you have someone who is known to be infected and you're separating them from people who are not known to be infected. So usually in the hospital, that's very common, whether it be actually an infectious disease or even just something that has grown out in culture. Quarantine is much less common. In fact, the COVID-19 outbreak is the first time there have been federal quarantine orders signed in over 50 years. So we really are in a very unusual situation. In terms of some do's and don'ts, I think the do's is as much as possible, do what you've been asked to do. In both instances, you need to try and minimize your contact with other people, particularly in situations of isolation, because those are the situations where we can be quite confident that there's a high likelihood of infectiousness for someone who has documented COVID-19 and who has symptoms. Some of the other things that can be done is making sure that people have enough food, that they have other medications, the things that they need to continue life until either they've recovered or are through the 14-day quarantine period. And this is an example of how we have to be together as much as possible, even though it may be done at a distance. So if you have a neighbor, check on them by phone ideally, or just a knock on the door and take a few steps back from the door to see how they're doing. It's also an opportunity for particularly supporting older people, or particularly people in isolation that we really don't want to be going out to the grocery store to be able to get food and basic supplies to them. This is a role that I've just observed that many faith-based organizations have taken on in terms of how they can do lay ministry, particularly with their younger people who are at lower risk, and taking appropriate steps to prevent the risk of transmission of infection, but also making sure that people who are in quarantine or isolation are getting what they need.
Great, thank you. So many rural communities have seen their hospitals close or decrease the number of services or amount of services that they're able to provide. What are your suggestions for those communities where either their hospital's closed or they're not providing a full range of services?
Yeah, you know, this actually points out a larger issue of the things that were challenging for us in rural and frontier areas when it's sunny and 70 degrees haven't gone away, and things like hospital closures and lack of access to care are only worse during a time like this. So this is where planning, if you're not yet impacted in terms of how people might be transported or how they might get care, is critically important. Sometimes if the hospital is cut back, or even if it's closed, if the building can still be occupied, there may be opportunities to reopen, at least to provide low levels of care if there's volunteer staff that can be made available. I don't know of rural examples of that yet, but that actually did happen in Chicago, where a hospital that had closed a number of months back was actually able to reopen to provide care for people who are relatively mildly ill but unable to take care of themselves at home.
Great. What are your suggestions for rural communities regarding setting up isolation and quarantine spaces?
So the thoughts on isolation and quarantine is ideally to be able to do it at home, if particularly people who are infectious or potentially infectious can be separated from those at higher risk. Beyond that, it comes down to what resources you have in terms of where people can be housed. The issue of mass housing is, I think, always problematic in a situation like this. While after a tornado or an earthquake, people might be housed in a gymnasium and fairly close together, that's not a good option during a pandemic, particularly for isolation of people who are actually actively ill. So it's going to depend on what's available locally.
Great. We have a bunch of questions about testing. Where would providers, hospitals, or health clinics in rural areas get testing kits?
So the providers would not be getting testing kits. And I think this is where the use of the term kits has been misleading, going back to actually when we started using it in terms of describing what was provided to state health departments. The current PCR technology is, when we were using the term kits, was basically a package of reagents and certain supplies that could test anywhere from 400 to 1,000 people. So it's not like a home pregnancy test kit or a rapid flu test, something that can be done in anybody's office. It's actually a fairly high-tech procedure. As the FDA has worked to approve a broader range of the nucleic acid amplification tests and things like PCR, that's helped to push it out further, but still, in general, these are going to be tests that are mainly available either in state public health labs, large commercial labs, larger hospitals, and sometimes in larger clinics. So that's why earlier I was saying I think what we're all really hoping for as soon as possible is something more like that rapid assay that could be done in the provider's office. Right now, the providers have a couple of options. One is to work through the local or state health department to get specimens to the state lab, or to work with the commercial providers that they work with, who also, many of them are now running the assays as well.
Can anyone get tested if they want to, or should we be prioritizing certain groups for testing?
Well, the CDC's put out some guidelines for prioritization, recognizing that the global supply of some of the reagents and the equipment are in fairly short supply. So the people that we would recommend prioritizing are people at higher risk of severe illness, people who are hospitalized, so appropriate infection control procedures can be in place, and then also healthcare providers, because we want to make sure that no one who is sick and potentially infectious is taking care of patients and potentially exposing larger numbers of people. In general, you know, if the test is, in some areas, the testing is more available than in others, but we do recommend it be limited to people who are actually experiencing symptoms of infection, because we really don't know what the meaning of a test is in someone without symptoms. A negative test in particular doesn't tell us anything, and we would be concerned that someone might feel a unreasonable sense of safety because they may still be in the incubation period, and the results of that negative test in the face of limited resources for testing may not be very helpful.
So you've talked about rapid testing. What's involved in actually getting tested, and when are the results available at this point?
So we have changed those guidelines as we've learned more about the results that we're getting with the assays. And now it's a single swab. It's what we call a nasopharyngeal swab, or an NP swab, which involves passing the swab back through the nose, literally almost as far back as it'll go, although we're getting more and more data that it can also go back just an inch or two, and we might be able to get good results as well. It's actually a very safe procedure. I once did over 500 of them in a rural Alaska village in one day, so it's not very time consuming. And the testing, then the swab goes into a viral transport media or some type of vial and goes to a laboratory. The turnaround time after that depends on a couple of factors, such as shipping time, and then whether or not the lab is caught up on any backlogs. Here at CDC, we can do the extractions in about 4 to 6 hours, and usually running the assay is just a few hours after that. There are some newer high throughput technologies that can provide more rapid results as well. So I think there's a lot of progress made in terms of being able to increase the throughput and get more timely results, but it's still not all the way out in the provider's hands.
Great, thank you. There's some questions about when people, if they are sick with COVID-19, when are they, or they've been exposed, when are they no longer contagious? When can they go back to work?
Yeah, so we're still learning a bit about that, and this gets back to the earlier question about viral shedding. The PCR can remain positive in some people even after recovery. The data on actual recovery of the virus suggests that it's much lower than that. So currently the guidelines provide two options. One is to get 2 swabs 24 hours apart that are negative. And again, this is after a positive test. This is not just any nose that walks in off the street. The alternative, because of some of the challenges in getting tested, is that it would be at least 3 days after recovery of symptoms, particularly fever, and at least 7 days after onset of illness. The one provision in all of that is if someone is a healthcare provider, because it is possible they would still be shedding virus, although less since they would not be coughing or sneezing, they should wear a mask when they return to work. In that situation, the mask is not to protect the person wearing it, but rather to protect the people they are in contact with. And for healthcare providers, any healthcare providers who are listening, it's now more than ever, hand hygiene is important. So that 20 minutes with 20 seconds with soap and water, or using an alcohol-based gel. I do recognize that if you're seeing patients all day, soap and water that many times can be pretty hard on the hands and lead to a lot of chapping. So fortunately, there are some products out there that will help protect your skin and also do an appropriate disinfection.
Can people be reinfected if they have been exposed or been ill, or do we think that they would be immune?
So again, it's a brand new disease and virus, so we're still learning. What we know about the common coronaviruses, and this is a family of about 4 coronaviruses that primarily cause cold-like symptoms, is that there is an immune response, and it may provide protection for a period of time, but there is a risk for reinfection somewhere down the road, usually a period of years, not weeks. At this point in time, we are learning about the immune response to infection. There is an antibody response, and that also opens up some doors for how we might assess better how this infection spreads and what's the spectrum of illness that it causes. But we really don't know for sure if people can become reinfected or when that risk of reinfection may occur. At this point in time, we really don't have documented instances of reinfection. There have been reports of people who are PCR positive, then PCR negative, PCR positive again, but we really don't know exactly what that means, because as we were talking about earlier, the PCR detects the RNA, the genetic material of the virus, and doesn't necessarily tell us that what's present is infectious virus itself.
So you mentioned masks. Should hospitals and clinics be stocking up on masks and other PPE? Should people in the community be using masks?
Yeah, so healthcare situations are different, and to be very blunt, if you can get it, it's a good idea to get it. but a lot of the PPE is in very short supply right now. So it's important that whatever PPE is available, that it's managed very carefully, because we know, again, getting back to some of these global supply chain issues, it could be depleted, and then we're going to have to be talking about what are some of the next best options to be able to protect our healthcare workers. In a healthcare setting, the focus has primarily been on filtration masks, things like the N95, and that's particularly important when there's going to be something that could potentially aerosolize the virus. An example might be a procedure that involves respiratory secretions, probably even suctioning a patient that's on a ventilator. In terms of what might be useful in the community, in general, CDC has no firm guidelines on that one way or the other. There's not a lot of evidence that wearing a mask in the community provides any additional protection over just basic hand hygiene. And I don't think I've mentioned trying to keep your hands away from your face, but that's part of how if your hands are contaminated, you avoid inoculating it into parts of your body that can become then how the virus gets in and causes the infection. There may be a role for people who are exposed or who are in recovery to wear masks, again, not to protect themselves, but to protect those around them. And that's an area where we're doing some very active research, and there may be newer guidelines coming out. And having said that, I think even though we've touched on this a few times, it's important to recognize this is a new disease. We are learning as we go. It's very humbling as we recognize that sometimes what we learned 2 weeks ago, we learned something new, and the recommendations may need to change. So I really encourage you, as much as possible, keep an eye on what's coming out, either at your state health department website or at cdc.gov/COVID-19.
The next question is about treatment or management. Does Plaquenil help as treatment or as prophylaxis for frontline healthcare providers?
So let me start with a very broad statement. Currently there are no proven medications that will treat COVID-19 and that have documented improvement in outcomes. So let me start actually with Plaquenil, or hydroxychloroquine is the generic name. There are some mostly uncontrolled data coming out that are encouraging. The nice thing about hydroxychloroquine is it actually is FDA approved for other purposes, mostly treating different types of autoimmune or rheumatic diseases such as psoriasis. So it is available. There's not a lot of really hard data for treatment yet, and we are working very closely with NIH to develop guidelines and be able to gather whatever data is available, particularly from China, where there has been more experience with this. Chloroquine is another drug that is fairly readily available, less data as well. There is an antiviral drug called remdesivir that is not FDA approved for any purpose right now, but is in randomized clinical trials right now, particularly for treatment of more severe infections. And we hope to have data on that soon, because some of those trials started in China nearly 2 months ago. There has been at least one fairly large trial completed, and mostly data that's coming out of China, again, about some of the protease inhibitors, the class of drugs that are used for treating HIV, lopinavir and ritonavir combination. Unfortunately, they were fairly disappointing in terms of really documenting that there was improvement in symptoms or outcome, and actually there was no evidence that it reduced viral shedding. So I think this is an area where you have to monitor the science closely. Hopefully we will know more soon, but at this point in time, there's no proven treatment that's going to make outcomes better. The question about prophylaxis is a very good one because I think many of us are familiar with that, with where we were at in 2009 with the influenza pandemic. We had oseltamivir, an antiviral drug that was useful for treating people who had exposures or critical infrastructure individuals prior to the onset of symptoms to prevent infection. There's basically no data on that with COVID-19 at this time.
Does ibuprofen exacerbate symptoms of COVID-19?
Yeah, thanks for asking that question too, because I know that is one that has come up based on some reports that came out of France. And those were really anecdotal reports and haven't been observed as much elsewhere. So at this point in time, we have no recommendations against use of ibuprofen or other non-steroidal anti-inflammatory drugs.
We've received several questions about smoking and tobacco use. So either sharing of tobacco products increasing risk of transmission, people who are trying to quit are becoming potentially more anxious and maybe smoking more or relapsing, or what recommendations would you have for somebody who has quit to stay in that status?
Yeah, so let's start with the question about sharing cigarettes or whatever. So in general, sharing anything that goes in your mouth is probably not a great idea, but it's even worse idea right now. So it's really, it certainly could be a way that COVID-19 is transmitted. In terms of a question that I think many of us are looking at the data very closely about is whether or not cigarette smoking itself is a risk factor for more severe infection. What's really intriguing is the epidemiology from China, where the death rates among older individuals are much higher, but they're much higher among men than among women. And the smoking rates among men in China are quite high, whereas among women they're much lower. And so certainly one of the hypotheses is that there may be a very particular role that cigarette smoking is playing in increasing the risk of severe COVID-19. So I think the bottom line there is maybe more for providers is we need to do everything we can to be able to support people who have ceased smoking, to be able to prevent restarting smoking. This also, I think, highlights that these are stressful times, and there are ways other than using tobacco that to manage stress.
Great. So we have a couple minutes. I still have a bunch of questions, but let's end on prevention. So what can community members do? So churches, restaurants, civic leaders, people in the community, what could they be doing right now?
Yeah, so a couple of areas. First of all, we've talked about social distancing, but that is very important to be able to, as I say, stand together, but at least 6 feet apart, because it's going to take a community response to be able to address this. Being able to limit or postpone gatherings are important. I saw kind of an amusing picture of a wedding that was held outdoors, and there was actually a grid on the ground where all the participants stood at least 6 feet apart. And I think the groom did get to kiss the bride, but other than that, there was no one was in contact with anyone else. Although in general, it's probably better to postpone any kind of gathering like that. The impact on small businesses and restaurants cannot be underestimated. If you're able to support your restaurants that are providing takeout services, a number of them actually now have donations, ways to be able to help their employees that may currently not be getting paid. That's important. And I think as we were discussing earlier, know your neighbor and find out if they have particular needs, because there's a lot we can do remotely and even with minimal face-to-face contact to be able to help one another through these difficult times.
Great. Thank you so much, Dr. Butler. We at CDC hope that this information has been helpful to our rural partners and stakeholders. You can continue to send questions to ruralhealth@cdc.gov. That is the mailbox that we monitor regularly. And with that, we will close this call. Thank you.
Thank you, everyone.